Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, as you know, at Hetero, we market products in different therapy areas like in gynecology, orthopedics, derma, etc. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as we know, is used for prophylactic management of PPH. PPH is a condition which can lead to disaster, which has the potential to lead to disaster. While there are several papers and guidelines which suggest the use of carbetocin, we would like to know the doctor's experience on use of carbetocin. Today we have eminent speaker Dr. Rachna Jindal Goel with us to share her experience on carbetocin.
Yeah, good afternoon, everyone.
Good
Good
afternoon.
afternoon to my
Welcome, madam.
seniors, and I am grateful to Hetero Health for bringing me here. As we all know, we have been since long. PPH is a very well-known entity. In days before there was any medication, even the Taj Mahal was built because Mumtaz Mahal died of PPH. So it has the PPH has a there is a almost an incidence of 2.4 per million births. So it is quite humongous. And had we not been able to manage with the drugs which are available now, like oxytocin, methergine, misoprostol, we would have lost a lot more mothers than we are losing now. And now the latest kid on the block is carbetocin. Since methergine was outdated, we relied a lot on oxytocin, but oxytocin had its fallacies. Oxytocin, there is a new drug now which is called carbetocin, which is a synthetic analog of carbetocin, but which with much lesser side effects, which much longer duration of action. And so we should all be using it now. I shall be highlighting the mechanism of action and the prolonged action and the less side effects of this drug during the PPT. I have been using it for 2 years. It was initially expensive when it came and also needed to be stored in the fridge. But now the newer heat stable preparation is come in the market, which is much cheaper and allows us to use it in scenarios. See, we are staying in Delhi. Most of us are staying in third tier cities, but PPH also happens in villages. So where there is no refrigeration, no fridges are there. So this newer modality, the new carbetocin, which is heat stable, allows the use of carbetocin even in village situations, in rural backgrounds where there is no fridge. It can be given intramuscular as well. It can be given IV. Even a dye can give it IM, and the cost has become very less now as compared to previous, which we'll see during the course of the PPT. Now, as I embark upon my first case in a vaginal delivery, I had a 33-year-old, fourth gravida with 3 normal deliveries. At 37 and a half weeks of gestation, she came with labor pains and leaking since 2 hours. The patient was stable, she was full term, everything was okay. She was at 8 centimeters and she delivered normally. There was no problem with the placenta, and membranes. And we chose to give carbetocin in this case because see, there are high risk factors for PPH. In this case, she's a grand multi, and then she has come in almost second stage of labor. Such grand multis, all their the muscle strength becomes lesser, and they are prone to PPH. There are many more cases where we expect that PPH will happen, so it is better to use carbetocin prophylactically rather than wait for PPH to happen, then use some other modality, say methergine, oxytocin you use, and then you use carbetocin. When you suspect in high risk cases, carbetocin is the choice of drug.
Next case, sir.
So in our second case, which was a cesarean section case, this was a 25-year-old girl. She was a second gravida, previous normal delivery, but this time she has twins, and the first baby was breech presentation. Even otherwise, we are now moving towards cesarean section for all the twins. The patient was totally stable. There was no high risk factor. except that the uterus was over distended because of the twins. An emergency cesarean section was planned. In this case, oxytocin was used, which could not control the bleeding that effectively. So 40 units syntocin on drip was used. But even then, we could not control the bleeding. We had to resort to again carbetocin, and even B-Lynch sutures had to be given. The bleeding was controlled and the patient was stable. Had we used carbetocin initially prophylactically, I feel that we would not have been pushed into B-Lynch sutures, and also there was no need of oxytocin. I would not have been even, there was no need of blood transfusion. Even for this patient, we had to transfuse 2 units of blood. So I have made it a dictum that whenever I have twins or whenever I am suspecting high risk patients who would bleed, who will bleed more, like, over distended uteri, like we have polyhydramnias, we have grand multiparas, we have twins, and we have previous history of PPH, we have any previous history of hypertension. In those cases, I placenta previa, I use carbetocin as the first line of management for PPH prevention. Even I don't wait for PPH to happen. Yeah. So we had another patient. This was a woman who was 28 years old. She had 2 abortions. So the pregnancy was precious, with 38 weeks of pregnancy with moderate pregnancy induced hypertension. So she was on aspirin since 10 weeks, and which were continued till 36 weeks. Arginine was given, labetalol was given to manage her BP. The pregnancy was going on fine. The BP was controlled. Ultrasounds and blood reports were normal. We induced her at 38 weeks by sweeping and stretching, and ARM was done at 3 centimeters using, and at 3 centimeters we started giving her oxytocin drip to augment her, and later on, even we started her on IV Magself. So continuous labor monitoring was done, but outlet forceps was applied to deliver the child. A 2.7 kg baby was delivered, normal Apgar 9 and 10, but we used prophylactically, we used carbetocin in this case, and we even continued oxytocin drip because we had used Maxelf earlier, which causes uterine relaxation. There was no PPH and the patient recovered well. There is some. You have muted yourself, Dr. Prashant.
I'm sorry. I
Yes.
said, yeah, carbetocin was used essentially because of prior to abortions, I suppose, not to take any risk.
Yes, and she also had a moderate PIH history. They're more prone
Okay,
to PPH. Then
okay,
she had
okay.
an outlet forceps application, and the third
Mm-hmm.
thing was that she was
Magnesium
induced by
sulfate.
oxytocin.
Yes,
Oxytocin, when you are using it for prolonged time, it causes receptor desensitization, and
correct,
it would
correct,
not
correct.
work. Then later on, when you use it for PPH management, prophylactically or otherwise, it would not work.
It was not.
In such
And
cases, carbetocin comes in handy. We must always be armed with carbetocin and then use
correct,
it
correct.
prophylactically itself.
Even
Even
use of
Maxilf
Mac.
is a uterine relaxant.
Yeah,
Yes, sir.
that's what I was asking. Even Maxwell
Yeah,
will do to it.
yeah.
Because wonderful cases, madam. You realize the importance of carbetocin. I mean, some of these questions which you have received, you have said your experience with carbetocin. Have you seen any failure with carbetocin, madam?
No, I haven't seen a failure. In fact, when I started using it initially, I remember in my first case, the patient had palpitations, and we had to call in the physician, and we
Anesthetist.
were all
Yeah.
very hassled. But ECG and all were done, but everything was okay. I think we were very scared, and I think maybe the anesthetist gave the shot too fast. The
Fast.
100 microgram injection should be given over 1 minute,
Yeah,
or if
yeah.
you or if somebody is really worrying, then it should be given IM. After that,
Correct,
I have
correct.
had no problem, and our carbetocin has always worked. Now that the price has decreased, we are free
And
to use it now.
yes, and the more important thing is in the interiors because it's a single injection, not a drip required. I mean, in the interiors, all these things are hassles. And cold chain also is an issue because even in places like Mumbai, we have got power outages at many times.
Yes, of
And
course, we have been
yes,
storing methergin and oxytocin in
exactly.
fridge.
Exactly. And power
Yeah.
outage, because of power outage, their efficacy can be low. And so with carbetocin, that's a major advantage, I suppose. Practical advantage of not
Yeah,
requiring
that's
the
the
food.
major practical advantage. So it can be used in villages even,
Absolutely,
where there is
yes.
no refrigeration, there is problem of electricity. It can be used. It
And
is stable for
yeah,
2 years. It has shelf life,
correct,
and
correct.
even at 30 degrees centigrade, it can be kept. It
And
doesn't
we do
need
not know
fridge.
how much, yes, and we do not know how much of medical help also they will have at that time in the interiors.
I have some
What
issue
the,
in the yeah.
can you hear us now?
Yeah, yeah.
What patient profile, in which patient type of patient you can anticipate PPH? Of course, PPH, is a thing which we say expect the unexpected. In any patient, you can get PPH at any point of time. But is there any patient profile in which you can expect PPH?
Yeah, as I said, any over distended uterus like twins,
Yes, twins.
polyhydramnias, any previous history of PPH, any grand multiparas where the muscle is weak, fails to contract after giving birth to so many children, placenta previas, and per se, if there is some coagulation abnormality and all that, we cannot predict. But there are certain cases like hypertension and all where we can anticipate, or liver function
Correct,
disorder where
correct.
we can anticipate a coagulopathy, and at
Even
that time it is better to be armed with carbetocin.
absolutely, absolutely.
Yeah.
Even diabetics can make a patient predisposed to PPH. Diabetes can make a patient predisposed.
Yes, a diabetic patient can very well take carbetocin, no
Yeah.
problem.
No, no, no. Can diabetes make a patient predisposed to PPH?
Yes, because the baby is large and we have hydramnios,
Large,
there are
yes,
both the
yes, yes,
problems.
yes, yes. And post date, any, I mean, chance of getting PPH post date, post due rather.
Postdatism, again, sometimes they are in prolonged labor and the baby, there is macrosomia also because the baby keeps
Yeah,
growing in
yeah,
postdatism.
growing. Correct,
And
correct,
then there is some issue that the labor is not taking place, there is prolonged augmentation, we induce
correct,
labor,
correct.
we augment labor. All these factors again predispose to PPH.
Right. So these are the patients where we can expect a PPH and take prophylactic precaution. When would you actually prefer a carbetocin or oxytocin? I mean, oxytocin is one brand which we have read in textbooks, which we have always followed. Uh, our textbooks of gynecology always mention oxytocin, but where actually you would prefer, in which specific cases?
In
In
all these cases
oxidative,
which we mentioned just now, the high risk cases.
high risk
But the
patients.
only problem is that carbetocin cannot be given before delivery of the baby. Although
That is
oxytocin we
correct. That
can
is
give for
correct.
augmentation
Yes,
of
that's
labor,
correct.
induction
That
of
is
labor,
correct.
but carbetocin cannot be given for induction or augmentation of labor. It works wonders. Whenever you're suspecting PPH,
Right, no?
without fail, use carbetocin. There is
Both
no
the
problem,
in,
absolutely.
both the intensity of contraction and the frequency of contractions are increased, I suppose, with carbetocin.
Yes, the IV injection hardly takes a minute to work, and it
Hmm.
almost for 1 to 2 hours the effect is there. And if you
Oh,
use the
that's
IM
enough. Yeah,
injection,
yeah.
it takes almost 2.5 minutes to work, and the effect stays for 2 hours, 3 hours. And
That's
the
enough.
best
Yeah.
part is that you don't need to give a follow-up oxytocin drip,
Absolutely,
and then
absolutely.
again monitor it and see whether it is running too fast, too slow, and
Correct.
very very importantly, there is no water intoxication.
Yes, yes. With the oxytocin many
There
times
is no
there is ADH.
antidiuretic
Yes,
effect.
yes, yes. ADH effect. And most important is the practical application of all this in the interiors of our country, because this single injection, give one injection, the effect is there and it's over. Rather than giving a drip, again waiting and monitoring patient. I mean, these are the places where carbetocin actually scores. Can we use carbetocin in case of retained placenta?
Yes, yes, we can use carbetocin in case of retained placenta. It works well, and also intraumbilical use of carbetocin has
Yeah.
been
Yes,
documented in such cases. Although I
such
haven't used it
cases.
myself, but
Mhm.
because we have retained placenta, patients come rarely. But
Yeah, yeah.
so in that case, you can use the umbilical vein to inject
Mhm.
carbetocin, and it helps in the expulsion of placenta, and also avoids the so-called the hesitation that we have in using carbetocin
Correct,
on the
correct.
patient, so it avoids going into the systemic circulation of the patient.
Yes, 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 that is important.
Yes,
Can we use carbetocin in the Rh negative mother?
absolutely, there is no problem, we can use.
Of course, because here, PPH is controlling PPH is very important. To get a Rh negative blood itself is an issue. Otherwise, can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
Yes, definitely we can use carbetocin for prevention of PPH where oxytocin doesn't work.
Hmm.
Oxytocin doesn't work because as I said, the receptor desensitization takes place because generally the patient
Correct.
is in prolonged labor for 12 hours, 10 hours before we label her as, either failure of induction or she delivers.
Correct.
Definitely,
Correct.
induction has to be with oxytocin has been continuing. Then oxytocin fails to work. That is one most common problem with oxytocin. Then it fails to work at the time of delivery when we need it to contract the uterus.
The receptor fatigue happens, sort of.
Yeah.
Is there any specific cases where you would prefer an IV route over IM route? IV, of course, would act fast, and IM would ask for a longer time, act for a longer time. But any specific place where you prefer?
Yeah, see, it is not as if I would prefer. I would definitely prefer IV route only because,
No,
but it should be given in a,
slow.
cautiously. It should be
Yeah, yeah,
given,
yeah.
yeah, slowly. It should not be given as a bolus.
Bolus. Correct.
But in circumstances again, rural setups where only IV access is not available,
Correct.
you are in
Correct.
a
Correct.
rush.
Correct.
IV cannula is not being put. It has come
Correct.
out.
Correct. Correct.
Then you
Correct.
can give it IM.
I.
Although the effect is sustained
Yes.
in both the routes, and there is a study which says that it is equivalent to almost 16 hours of continuous oxytocin
My God,
infusion.
that's
So
a
it
big
is
thing.
that
That's a
good
yeah.
for causing contractions.
Correct. Correct. So use of IV is more important. I mean, IM is an option. Sometimes they can do, but otherwise they should prefer IV for
Yes.
immediate access. Suppose if a patient is not responding adequately with carbetocin, what additional neutrotonics would you use?
See, it is rarely that the patient doesn't
Mm,
respond to carbetocin. The result is very good. But
mm.
we can use other modes which we have, like we have oxytocin, we have methargine. Especially methargine cannot be used for hypertensive patients. Apart
Hypertensives,
from
yes.
that, we can use methargine. We can also take the support of misoprostol and prostaglandins, although they are not very, very beneficial and they have a lot of side effects.
Yeah, yeah, carboprostol, yes.
Yes.
What are the specific advantage of carbetocin over these drugs? Like methyl ergometrin, yes, hypertension, but misoprostol, misoprostol and carboprost, what is the specific advantage?
Yeah. So we have been using oxytocin since long, and we have been using
Mm, mm.
mesoprost since, like, say, 20, 25 years. Carboprost,
Correct,
methergine
correct,
has been
correct, correct.
there ever since. But carbetocin is a synthetic analog of oxytocin. So what has happened by modifying it, that it acts for a longer duration of time. With oxytocin, what happens is that you give the drip, it works and it goes off. The moment you stop the drip, the effect goes off.
Goes
But
off.
when we are giving carbetocin, the effect stays prolonged, and it is as good as giving 16 hours of
Yes,
oxytocin
yes,
drip
yes, yes, yes.
continuously. The best
Correct.
part is that you don't have to monitor it later on. And
Absolutely.
secondly, it is heat stable preparation is
Mm,
available.
mm, mm,
As we
mm.
have mentioned, it is stable for 2 years, and at 30 degrees centigrade. There is no need of
Degradation.
refrigeration. There is no hassle of cold chain maintenance. So the batch to batch variability also doesn't differ. Because so many times the transport problem is there.
Yes,
They
yes,
cannot
yes,
be
yes, yes.
transported properly in the
Absolutely.
refrigerated containers. But with
Absolutely.
carbetocin, it has become very easy. Then the thing is that oxytocin IV, the effect goes as soon as you stop it. But carbetocin, if you have given, the effect stays for 2 hours. There is a prolonged effect. Even IM carbetocin, the effect stays for 3 to 4 hours.
And advantage
And
of
yes, oxytocin, then oxytocin has side effects of
water
the water
retention.
intoxication that we have all observed that whenever we are giving the Synto drip later on, generally in cases of cesarean or high risk patients, we like to cover our patients with 4 hours, 6 hours of a oxytocin 20 units drip, which keeps going slowly. But then we have always observed that the staff nurse will come and tell you that the urine output is not adequate. Then
Mm.
you sometimes you wait, sometimes you're using Lasix, but we know in our hearts it is due to oxytocin. It acts on the V2
Oxytocin.
receptors, since
Correct,
both of
correct,
them are posterior pituitary
correct,
hormones.
correct,
This
correct.
effect has been overtaken by the synthetic analog, the carbetocin.
Carbetocin.
So it is very, very weak agonist at the V2 receptor. It doesn't cause water intoxication at all. So that hassle of decreased urine output and that tension is also not there with carbetocin.
Absolutely. Plus, there could be even, electrolyte imbalance, sodium, potassium, because of water retention.
Yes,
Yeah.
especially in cardiac patients.
Yeah. And carboprost, advantage of,
Carboprost has been, in fact, outrightly rejected by WHO
ah,
now.
Acha.
Carbetocin is in, and carboprost has been taken out of the list from,
Okay.
by WHO recommends not to use carboprost because it has
Adverse effects.
very severe side effects of vomiting and diarrhea,
Yes.
and
Yes.
especially
Yes.
it is contraindicated in asthmatic patients where
As
we
it's
can
prostaglandins.
conveniently
Yes.
use
True.
carbetocin. There is no
Correct.
problem, and action is also much better.
Absolutely. At first. Yeah.
Yeah.
Should carbetocin be kept as a reserve RAM? You already answered this. It should be used as a first line drug.
No, I don't think now we should be using carbetocins now, since in
Absolutely.
initially the
You are unaudible. Not. We can't hear you, madam. Your presentation is. Jayant, what must be happening? Ah,
yes.
yeah. Yes. Yes, it should not be kept as a reserve drug. Correct. How do you compare side effect wise? I've already answered this, especially hemodynamic profile wise. Is there any hemodynamic like blood clots or embolism with carbetocin?
No, 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 not at all. In fact, the cardiac effects, the skin rashes,
Ah,
and all are reported to be zero, not even zero point 0.1.
correct, correct,
They're
correct.
reported to be
And
zero.
any side effect of carbetocin you have seen in your practice now that you're using carbetocin very commonly? Any
No,
common side
initially we
effect?
had that patient with
Yes,
palpitation
you
and
said
all,
yes.
but I guess there was no problem. Even that patient recovered well. There was absolutely no problem. I think we were more scared because we
Yeah,
were using a new drug.
correct, correct.
We had panicked.
Just to conclude, one liner, take home message.
Yeah, I would say that even in India, the champion trial has been conducted. It is the carbetocin hemorrhage prevention trial. It is done in 23 centers across 8 countries, in which even Indians have taken part. France has also taken part. So it is tried and tested even on Indian, ethnicity. So we
Patience,
don't need to
yes.
worry. Generally, we are using drugs which have been used in the US or in some other
Correct,
countries,
correct,
and
correct,
then
correct.
we differ from them. We always think that our metabolism is different, their metabolism is different. How would it work with our people? But this has been conducted. The trial has been conducted in almost 48 studies have been done, and 8,000 patients have enrolled, and it has been found to be very safe. Even the WHO, the FIGO, the French, and the Canadians outrightly have started favoring carbetocin over oxytocin. They say that it is equally efficacious with lesser side effects. So the day is not far then when carbetocin will be used right, left, and
First
center,
line.
and there will be no place for other utrotonics.
With all these practical
I recommend carbetocin very firmly.
yeah, this is very important. Thanks so much of insights because people have been leading Western trials and clinical trials, but practical experience is what is more important. And hearing from people who have used it is more important to the audience who have gathered here. Thanks, madam, for this wonderful presentation and insights. We really enjoyed the presentation.
Thank you so much,
And
Dr. Prashant. It was a pleasure to be here.
yes, and I thank all the participants who took time from their busy schedule and attended this webinar. Thank you, Marketing Team Hetero, for conceptualizing and organizing this webinar. Thank you, Field Personnel Hetero, for super coordination to make this successful. Last but not the least, thank you, IT Team Hetero, for all the IT support. Thank you. Thanks, all of you.
I would
Signing
like
off.
to also
Wish you very
thank Dr. Narendra, who coordinated the whole event and
thank
gave me
you.
an opportunity,
Yes,
and also Hetero Healthcare, Dr.
yes.
And you too, Dr. Prashant. You managed it so well. Very
Thank you.
beautiful management, very immaculate. Absolutely.
Thank you.
Thank you so much.
Wish you a very pleasant afternoon. Thank you so much. Signing off.
All.
Thank you. Thanks, Jayant. Yes.
Thank you, sir.
Thanks
Can
for
I?
yes, 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 yes.
Thank you so much. Okay.
Thank you.